Let's start with a scenario. A non-HIV immunosuppressed patient comes in with progressive dyspnea. You run the labs, right? And the LDH comes back completely normal. So can you confidently rule out Pneumocystis jirovecii pneumonia? Well, if you said yes, you just fell right into a classic board exam trap. But don't worry, because today we're going to completely dismantle these traps piece by piece.
Welcome to today's explainer on Pneumocystis jirovecii pneumonia, or PCP for short. We're going rapid fire here, focusing specifically on dodging those sneaky diagnostic traps and pharmacological minefields that exam writers absolutely love to throw at you on test day.
Here's our game plan. We'll meet the pathogen, look at clinical presentation and imaging, navigate the diagnostic traps, tiptoe through the pharmacological minefields, and finally wrap up with prevention and prophylaxis protocols. Let's get to it.
Section 1. Meet the pathogen and the identity trap. Now, examiners love to test if you've updated your mental flashcards. Older textbooks called this bug a protozoan named Pneumocystis carinii. But thanks to modern molecular techniques, they actually reclassified it as a fungus. And specifically, P. carinii only affects rats. The human-specific species is P. jirovecii. Because it's a fungus, its cell wall contains beta-D-glucan. But listen, here's the massive clinical takeaway for your exams. It cannot be cultured in vitro. Routine culture and susceptibility testing, literally impossible. You have to find it another way. And this underlying microbiology directly informs the risk profiles, which brings us to the CD4 count trap. Now, in HIV patients, the CD4 count is your ultimate compass. A CD4 above 200 generally means low risk, right? And dropping below 200 is that classic threshold where over 80% of HIV-related PCP actually happens. But hold on. If you've got a non-HIV patient, say someone on high-dose glucocorticoids or rituximab or a solid organ transplant recipient, relying on that CD4 count is a huge mistake. For non-HIV patients, a CD4 above 200 does not reliably exclude the risk of PCP at all.
Section 2. Clinical presentation and imaging. Spotting the differences. When looking at the clinical timeline, you really have to recognize how the patient's underlying immune status completely changes everything. It's actually a fascinating clinical paradox. You'd probably think the patient with HIV and profound immunosuppression would crash much faster, wouldn't you? It's exactly the opposite. HIV patients usually present with a really indolent, slow burn onset spanning weeks to months, often just starting out as mild exertional dyspnea. On the flip side, your non-HIV immunosuppressed patients will crash with a rapid, acute progression over just a few days. The underlying immune response just dramatically changes the whole timeline. So moving to imaging. A classic chest X-ray shows bilateral perihilar and symmetric interstitial infiltrates. But here's the trap. Early on, that chest X-ray can be perfectly normal. So if you suspect PCP, you need to push for a high-resolution CT, an HRCT. When you hear diffuse ground glass opacities, ring the buzzer for PCP. The HRCT shows abnormalities way before an X-ray will. In fact, a normal HRCT essentially rules out PCP entirely. Oh, and one more thing. If a vignette mentions an HIV patient who suddenly develops pneumocystis, those thin-walled air cysts, or a spontaneous pneumothorax, PCP needs to be at the absolute top of your differential.
Section 3. Navigating diagnostic traps. The stain game. Remember how we said you can't culture this bug? Well, if a board question asks for the single best, most common diagnostic step to confirm PCP, bronchoalveolar lavage, or BAL, is your absolute gold standard. You're washing fluid from the lungs, and it gives you a near 100% sensitivity and specificity. Once you've got that BAL fluid, you have to stain it. And you must memorize what each test is actually looking for, because examiners will try to trick you here. Methylamine silver, or GMS, is brilliant for staining the cyst walls black, but it will not show you the trophozoites. If you want trophozoites, you need a Giemsa stain. Immunofluorescence is fantastic because it highlights both. But watch out for the PCR trap. PCR on BAL fluid is incredibly sensitive. Actually, it's a little too sensitive. It can't reliably distinguish between someone who's just colonized with the fungus versus someone with active, raging disease. So PCR is really only useful for ruling out PCP when it comes back negative.
Okay, listen closely to this exact phrase. Foamy vacuated alveolar exudate. Burn this into your retinas. If you see this pathognomonic phrase describing an H&E stain on a lung biopsy, the answer is PCP. The trap here is that an H&E stain can't actually identify the organism itself, but that foamy exudate it leaves behind, dead giveaway.
Section 4. Pharmacological minefields. Navigating treatment contraindications.
So it's not enough to just diagnose PCP, right? You have to treat it without causing lethal side effects. Your absolute first-line defense across the board is TMP-SMX. It works by inhibiting the folate metabolism of the fungus, but you've got to pay extremely close attention to the patient type to nail the correct treatment duration. For moderate to severe HIV patients, or literally any non-HIV patient, you're doing a full 21 days. But if you have a non-HIV patient with only mild disease, you can shorten that to 14 days. Just keep an eye out, though, because HIV patients have a notoriously higher incidence of hypersensitivity to TMP-SMX, presenting with rash, fever, and leukopenia.
Now, what happens if TMP-SMX fails or the patient has a severe sulfa allergy? Your primary intravenous backup is IV pentamidine. But wow, is this drug toxic? First, you must infuse it very slowly, over at least 60 minutes, to avoid sudden, lethal hypotension. It can also cause renal dysfunction, neutropenia, and torsades de pointes. But the sneakiest, deadliest trap? Dysglycemia. Pentamidine can cause life-threatening hypoglycemia that strikes days or even weeks after the infusion, and it's often followed by hyperglycemia later on. You have to monitor their sugars obsessively. All right, quick Socratic question time to keep us sharp. Let's say IV pentamidine is just too risky, and you are forced to use the oral combination of clindamycin and primaquine for a patient who can't tolerate TMP-SMX. What is the absolute prerequisite lab test you must check before administering this combo? The answer is G6PD. You absolutely must check for glucose 6-phosphate dehydrogenase deficiency before handing out Primaquine. If you give Primaquine to a patient with G6PD deficiency, you're going to trigger massive severe hemolysis and potentially methemoglobinemia. Always, always check the G6PD status. Let's talk about timing, because timing is literally everything in moderate to severe disease. As the TMP-SMX starts killing the fungus, those dying organisms release a massive inflammatory payload into the lungs. To stop the patient from deteriorating from all that inflammation, you must add adjunctive glucocorticoids within 72 hours of starting anti-PCP therapy, but only if their room air PaO2 is below 70 or their AA gradient is 35 or higher. This is the standard of care, and it literally reduces mortality. Also, for your HIV patients, you need to initiate their antiretroviral therapy within 2 weeks of starting the PCP treatment.
Section 5. Prevention and Prophylaxis Protocols. Keeping PCP at bay. So how do we prevent this in the first place? Once again, TMP-SMX is your heavy hitter. It's the most effective first-line prophylaxis, usually given as a daily double-strength tablet, and it even gives you bonus protection against toxoplasmosis. However, be incredibly careful with aerosolized pentamidine. It is the absolute least effective option available. Why? Well, it's an inhaled mist, and the mist simply won't reach the poorly ventilated areas of the lung, leaving those pockets completely unprotected. Plus, it offers zero protection against extrapulmonary disease. You really only want to use it if all oral options, like dapsone or atovaquone, are completely off the table. Before we wrap up, I want to leave you with this provocative scenario. It's a classic vignette. Your patient is admitted, you correctly diagnose PCP, and you start them on TMP-SMX. Awesome. But on day 5 of this correct therapy, their oxygen requirements suddenly spike and they are clinically deteriorating. Do you panic, declare treatment failure, and immediately switch to that highly toxic IV pentamidine? No way. Absolutely not. This is one of the biggest exam traps out there, and it's testing your knowledge of pathophysiology. That clinical deterioration in the first 4 to 8 days is actually a normal, expected inflammatory response to all those dying fungi in the lungs. You don't switch drugs yet. You hold steady, maintain supportive care, ensure they have their steroids if indicated, and wait a minimum of 10 days before ever declaring treatment failure. So considering how perfectly adapted this fungus is to exploit a weakened immune system, it really makes you wonder, what other opportunistic pathogens are just waiting for that CD4 count to drop, and do you know how to dodge their traps too? Keep that in mind the next time you're staring down a differential. Thanks for joining this explainer, review the key takeaways, and go ace those boards.